So I'll kickstart the question in the theme of re-evolution and in the theme of training for transcatheter procedures. Questions for the panel. How do you get somebody mid-career who's been in practice now for about 10 years to train in the imaging that Dr. Lumdsen described or in the TAVR procedures that Dr. Kleiman and Reardon mentioned?
Well, you ask them if they want to keep working the rest of their life, or they just want to retire now. I mean, you know, it's when EVAR came along, and Alan and I were both still at Baylor. You know, I looked at this and said, well, I've got to learn this, and so I got sent a lot of open aneurysms. I started calling Alan on all of them and say, Alan, you think you could EVAR this? When the answer was invariably yes, and then I would ask, would you mind if I would scrub with you? And so I scrubbed on all these, and I kind of on the job learned. The difference is we're now starting to incorporate this in our training program. So we have two fellows, they're both here with us. Razvan Dadu is our cardiology interventional structural fellow, and then we have Moritz von Ballmoos, who's around here somewhere, who's our cardiac surgery structural fellow. So even now in the training program, you know, people are learning this. And I think that what's going to happen is folks like Razvan and Moritz are going to go to programs where they may not have a surgeon that knows how to do this, and they'll become the teachers on the site. But you know this, Basel. You're mid-career. I'm late career. You realize if you didn't learn how to do this, you weren't going to have cases to do. And look what it's done for your program.
And this is exactly the point that you mentioned, is that as difficult and as inconvenient as it is to take time out of your current practice, all the obligations from administration, clinical duties, EPIC, and all that stuff, it's really very, very important to give this a priority that it deserves. Dr. Lumdsen.
Yeah, I mean, I think Mike hit it. It's about attitude, and it's about you have to invest time in this. You cannot learn this with TAVR, okay? You need to be involved in the gamut of endovascular procedures. And I think the danger for cardiac surgeons is, oh, just let me scrub on some TAVRs where they don't really do anything, other than basically assure that, you know, you're checking the boxes, there's a cardiac surgeon there. You must be involved in this. No center is busy enough that you're going to learn endovascular procedures on TAVR alone. And, you know, cutting off my own throat, and to some extent, you have to be involved in every endovascular procedure that you can really get your hands on. And that's a commitment. It's not that easy, but the payoffs are huge. I mean, the guy you should be asking about this is Marvin Atkins. Go on, Marvin, stand up. I mean, Marvin is the newest faculty member down here. He's not even started yet. He's a guy who was a vascular surgeon, a mid-career vascular surgeon who decides he wants to be a heart surgeon. And he's just finishing with Joe Bavaria at Penn. He's coming to join. He's a double-boarded cardiac and vascular surgeon. Now, we still haven't figured out if he's crazy or he's the smartest guy on the planet. But, I mean, clearly he sees these skill sets really coming together. And to have a cardiac surgeon who has a complete tool set of endovascular procedures is absolutely transformational. I think it will change the specialty, actually. But, you know, to Mike's credit, I mean, when I came down here, he and I have worked together since then, and I'd always give him credit. He's the only cardiac surgeon in town who wasn't really, you know, the attitude wasn't, what's wrong with you, son? Don't you really know how to operate? But he basically saw that this was something, you know, he needed to get involved in. And now the guy is leading 3 or 4 national trials. That's the payoff for people who get involved in this. Marvin, you want to say something?
The question I was going to have for the group is, could you comment on the national coverage decision as TAVR becomes more and more...
Where's Tom McGilvery? Is he going to hide out and not answer that one for us?
So as TAVR becomes more standard of care, what's going to happen to the community cardiac surgery practice?
Well, you know, we can't talk about what the next set of guidelines are going to be, but the rumor is they're not going to be less restrictive, they're going to be more restrictive. And I think that people have realized that, you know, they need to keep this in a team-based approach. The question that somebody is it realistic to imagine that cardiologists will not take over TAVR? And probably about 80% of the places in the U.S. they already control TAVR, you know, already. And there's a surgeon that stands in the corner. You know, I have surgeons like Tom Wynn. I mean, Tom could do TAVR with no cardiologist in the room. But I think those are going to be the successful folks. There are some things we need to change. Right now, they still require 2 surgeons to sign off on every patient. You know, that was done to make sure we weren't taking people that were inappropriately low risk. We're not seeing those anymore. We're down to intermediate risk. I'm lobbying now to just have one surgeon sign off of them. And I think the real question for the future is if we get approval for low risk, should we have everybody that's over 70 getting a valve at least see the TAVR team to make sure they don't inappropriately get surgery if they're a good TAVR candidate?
Well, look, there's another side to that coin too, and that's how many practitioners in the U.S. do you need doing this without diluting the experience and without the skill set declining significantly? We see that in PCI, to a tremendous extent. There are, the ACC will tell you there's a shortage of cardiologists in the U.S., yet every practice I know of, huddles groups at least once a week trying to figure out how to get more patients into their practice. Those two things aren't compatible. We see that in the valve world too. The average cardiovascular surgeon does 4 mitral valve repairs a year. The number of cardiovascular surgeons who do, is it more than 50 mitral valve repairs a year is 4. We really don't want to see that happen in TAVR. And particularly, this gets a little easier to do. You have to do a lot of them to see and know how to manage the bad things that happen. So I'm not clear on what the ideal number is, but I don't think anyone else is either.
Get some questions from the audience. Dr. Wren?
Yep, thank you for a wonderful presentation. I have 2 questions. First for Dr. Reardon and Dr. Kleiman. So Dr. Reardon, a patient comes to your office, roughly 63 years old, bicuspid, with an SCS of 2.8, is begging you for a TAVR. What would you tell him?
Well, my operative schedule is open on Monday, Thursday, and Friday next week. I mean, right now, not everybody is a candidate for TAVR. As you know, the partner 3 had a bicuspid arm. We're designing a bicuspid trial for Medtronic. We need to learn a little bit more about this. And it's not just, can we implant them in bicuspids, because you and I are doing that every day already. The question is a bicuspid going to affect the durability and a few other things? I mean, I've had people that in their 60s that I wanted to put in a low-risk trial that Neal's told me, no, you just need to operate on this person. I think there's a place for surgery. There's always going to be a place for surgery. It is going to depend on the anatomy, though. I mean, a tricuspid valve in a 65-year-old that doesn't have any prohibitive calcification for sealing. If somebody really wants to do that, and we show that at least at 10 years it's looking pretty good.
Would your answer be different if he's tricuspid?
Might be. It might be. The answer is I would tell them, there's a lot of unknown data out there. The biggest issue is durability. But then again, I go to my surgical friends and say, well, what valve do you put in? They say, well, I put in a trifecta. And they go, well, how much durability do you have? And they say, well, I have 15 years. I go, no, you don't. Hadn't been out that long. Or I put in a Percival. Really good valves, very reasonable to use, but we don't have durability yet. And we don't have, there's only really a couple valves that we have really good durability on.
Yeah,
Dr.
the
Kleiman,
other side of
2.8%, but tricuspid, begging for a TAVR. What would you do, Dr. Kleiman? How would you recommend?
Sorry, I missed the first part.
Mid-60s, severe AS, tricuspid valve, SCS at 2.8%.
Well, I'd ask him how wealthy he is, because with that risk score at his age, CMS isn't going to pay for it. If he's 64 and a half, his private insurer is not going to pay for it. It means he's going to be stuck with the bill.
Assuming low risk gets approved. If low risk is approved, then
So if low risk is approved, what I'm going to tell the guy is, look, we've got really good data that TAVR will give you comparable or slightly better results than surgery out to 2 years.
And what you meant to say, Tom, was
let me finish.
was not mid-60s, but prime of life.
Yeah. So we have data from other studies out to 5 years, but beyond 5 years, when you're going to be 68, we don't really know. So you need to think about that.
One of the things...
That's the kind of discussion you have to have.
I would also put in minimally invasive aortic valve replacement within that. And oftentimes patients will take that because they're not too...
100% of the time,
Yes.
almost nearly 100% of the time, they'll end up taking it.
Absolutely.
Some of us need to be more convinced about that.
So let me, two words of caution. Then you can look back 10 years from now and say, you heard it first here. And that is, there's a lot of pessimism in the endograft world at the moment because what looks good for the first 5 years ain't looking so good when you get 7 to 10 years out. And it's not because the endograft fails, it's because the aorta is failing around at the endograft. We probably take out more endografts now than we are actually putting in. And so I don't think the story is going to be told until you've got 10-year follow-up in these lower risk patients. And you may well be, open aortic surgery may not be dead, and you may be taking these out and replacing them. And the other thing that we're seeing in the endograft world is infections. These are not immune to infections, and those are devastating problems that you're going to have to deal with. The second thing is, so that's a lesson from the endograft world. Now here's a lesson from the inferior vena cava filter world. First inferior vena cava filter was like a 20 French delivery system. It was made of stainless steel. It's working to this day. And then, much like what you heard Mike saying, it became, let's make this smaller. Smaller equals slimming down basically the nitinol struts and making it easier to deliver. Making it easier to deliver means more people deliver it, means that they're basically less selective. So the utilization explodes. And then all of a sudden, you can't go anywhere in the United States now without seeing, advertising from malpractice attorneys because of filter fracture. And is they're fracturing because these struts are smaller to make it more deliverable and make it more usable. And so I think you should focus basically on building the best device and worry less about deliverability down the line.
And one last real quick question for the panelists. So in Dr. Reardon's presentation, it seems like the trend is increasingly transcatheter valves for the treatment of aortic pathology. So the problem with training is you guys have a fellowship program. I see Dr. Rosswell in the back as well. Our residents focus on SAVRs, but should we switch? I mean, we have a finite amount of time to train the residents, so something has to give. I mean, it would be great to train TAVRs and SAVRs. Should we actually have residents train more in TAVRs? And if they want to do a surgical AVR, say, hey, let's go down to the cath lab? How do you balance that?
Well, let me ask you something worse. If you're going to train them in TAVRs and SAVRs, should they give up coronaries? I mean, we're learning we can't do everything. We're learning as interventionalists that the days of the general interventionalist are behind us. I think you guys are learning the same thing. The question is really, if you're going to take on something new, what are you willing to jettison?
But one of the things that I would say to that is you're talking from a quaternary level practice. Most of the world is not there, right? Most of the world is not to the level where you can only do TAVR or structural heart. And in most tertiary care hospitals, the interventionalist is doing PCI, they're doing TAVR, and they may have special interests, but I don't know that there is that many practices that do that.
I understand that, but part of our responsibility is to help figure out the direction we should be heading. And from everything I see, we're all heading in a very specialized direction because these things are becoming more complex. The tolerance for complications is getting lower and lower and lower. I mean, the complications that for us as a TAVR center were tolerated 4 years ago are no longer tolerable, and we get in trouble for things that 4 years ago we were told, well, that's the price you pay.
So, will Dr. Guy give a final question?
Thank you so much. So Norman Shumway made a very famous quote, which most people in the room probably know, that basically the only hard thing about heart surgery is getting to do heart surgery. Now, I'm not sure I agree with that, but I do agree with it when it comes to TAVR. My question for you guys is, if you look back at the history of vascular surgery, it was not all fun and games, converting that specialty to open to include endovascular. I remember I was at Penn, and the vascular surgeons there were being attacked by the interventional radiologist to the point where, they were taking them to the state board, trying to, take away their license because they were doing endovascular procedures. Now, those surgeons who were very courageous, and they pushed through that, and they fought that battle, and they, sought and gained equipoise on the endovascular front. We as a specialty in cardiac surgery, we've kind of become wimps when it comes to politics, right? I mean, there's no doubt that the majority of cardiac surgeons can train and do a TAVR, and certainly for the younger generation like myself, who are very well trained in endovascular and are as comfortable with a Lunderquist wire as we are a standard aortic cannula, there's really not a problem with skill sets. It's really a problem with the politics. You know, when I was in Philadelphia, we hired a guy, Grayson Wheatley, who had exceptional endovascular skills, and I watched this guy get pushed back to the back of the room by the cardiologist. And even though he was probably better than they were at that particular hospital with large bore, large catheter, stiff wires. So how are we as a specialty going to deal with the politics? Because for, 10 years now we've heard, learn what a Lunderquist wire is, learn what a glide wire is. That's all great. We already know that. How are we going to get surgeons into prominent positions other than the, select places where surgery and cardiology have found, ways to work really well together? Many places in the United States, no matter what Bavaria's study says, the surgeon is pushed to the back of the room. That's just a fact. And I think that's what most of us that still have 15, 20 years left in this profession are worried about.
Well, the good news is everybody's so nice in Houston, we'd never attack each other here.
Yeah, absolutely.
We don't know
New York
much
City,
about
too.
that. It's a real question. I think 80% of the program surgeons are just basically standing in a corner somewhere, in case they need a cut down, and then they're dictating it as co-surgeon because it's required. I mean, one of the reasons I got involved in this was I did not want to see my fellow surgeons get boxed out because I thought there'd be two types of surgeons that got involved with TAVR. There'd be old guys like me who got involved as seeing it as a way to control patient flow, but they didn't care about the technology, or young guys who really cared about technology who got shoved to the back of the room by the cardiologist. And I wanted to make sure that there was somebody senior enough that could stand toe-to-toe to cardiologists, even guys like Kleiman, who's really aggressive, and and we could learn to work as a team. I think the better things will do it. What we need to convince the surgeons is not just learning the technology of how the valves are deployed. You got to be there selecting the patient, talking about how you evaluate. If you can't do the three-mensio analysis, you shouldn't be doing the case. That's like saying you do a coronary bypass if you can't read the cine. And a whole bunch of folks come in and they just want to turn a handle. They're useless to me.
Well,
I told you, it's aggressive.
I want to hear this answer.
some of this has to do with the economics of how a department works. For most things, you're most productive doing the things that only you can do. There are a lot of, and look, I work with Mike on a daily basis. Mike does many, many of the things that I do too. But there are things that Mike can do that I can't do, a lot of them. And I assume it's the same for you. So, again, I want to reiterate, I don't believe every cardiologist ought to be learning to do this. I don't believe every cardiovascular surgeon ought to be learning to do this. I think among groups, and as we move towards more integrated cardiovascular groups, you've got to work out the economics. How many individuals in the group should be doing it? If you're a surgeon, how are you most productive? If you're a cardiologist, how are you most productive? How do I balance my TAVR volume, which I'm told doesn't pay very well, with my stent volume, which I'm told does pay better?
Okay, very good points. We'll continue that discussion over the exhibit and the break for the next 10 minutes.